Right, good morning everybody. We're going to talk about a couple of things today that focus on care coordination for Medicare beneficiaries. There's really two modules to this program, chronic care management and transitional care management. So you really have these two great options through Medicare that are underutilized currently. So hopefully one of these modules will be a good fit with your grant and the physicians and the practitioners working within the grant. I am not an attorney, so I have to tell you this presentation is just not designed to provide legal advice. It's just designed to provide education and resources. And should you have any questions after this presentation, you can follow up with me as often as you would like. So if you can call or email or whatever's convenient. It is up to date. As of yesterday, I checked, vetted everything through the Centers for Medicare and Medicaid Services and through CPT and etc. With the type of work that we're all in, I don't have to tell you the kind of the state of affairs that Kentucky's in. You've probably seen the same slides that I have where we're number one in a bad way. So one of the problems that we have is we have people that have they'll have multiple diseases, there are a lot of comorbidities going on there. So what Medicare did, because we have a pretty significant Medicare population, of course we have a huge Medicaid population in Kentucky right now too. Medicare started a few years ago sort of thinking about chronic care management, and they've introduced new codes, the medical codes that you use to send to Medicare in order to get reimbursement for. So they introduced some. As this says, chronic care management services, they consider them patient-centered. They support services provided by physicians and other health care professionals like a nurse practitioner or PA and clinical staff. The problem with chronic care management services before Medicare came up with these codes is physicians perform these services, but there's no payment for that because typically Medicare and many other insurers don't pay unless there's kind of a face-to-face interaction. You can have staff that work for you, and Medicare has a way to sort of build that. But so this was new when they started introducing this. I took this slide directly from the CMS website, although I think it's a CDC website. And you can see 2 out of 3 Medicare beneficiaries have 2 or more chronic conditions. 1 out of 3 have 4 or more chronic conditions. One of the biggest expense that Medicare incurs is managing those complicated patients. When you have diabetes, when you have COPD, when you have heart disease, all of those things that sort of join together. So it costs Medicare a lot of money, and they're trying to kind of get a handle on that through these different programs. The other thing that they're trying to do is not only manage these chronic patients, they want them to have a better quality of life. We all want that. We're living a lot longer. I listened to a presentation by a retirement specialist, and he said, you can expect to live till 90, and I was like, I don't expect that. But you know, who knows? But we are living a lot longer, and people are living a lot longer they're sicker, and it's costing more. So right now, the percentage of the U.S. population greater than 65, and you all probably know this from what you do, but it'll increase from 13% in 2010 to about 20% by 2040. There's 10,000 Americans that turn 65 every day, which means they're moving into the Medicare realm. So we are an aging generation. The CDC says by 2025, chronic diseases will affect almost half of the population. And chronic diseases account for 81% of hospital admissions, and I honestly would think that that's even higher, just from what I see from auditing work that we do sometimes. But so 81% of hospital admissions, 91% of the prescription filed, and 76% of all physician visits are due to managing chronic illnesses. So as you can see, it's not only a big problem, all trying to think of how we can manage it. The CDC has this great piece on their website that talks about chronic disease prevention. And some physicians that are sort of focused forward, they're trying to get a handle on this. We have one physician in Eastern Kentucky that does this. He's worked with the county that he lives in to do health awareness events throughout the year to try to at least get that on people's minds to help them live better with chronic diseases, but maybe prevent some. One of the other things the CDC said was that research consistently shows that effective chronic care management reduces the cost for chronic disease patients while improving their overall health. I can certainly see that. If you've got a patient and you're treating in total, if they've got 3 illnesses and if they were seeing 3 different doctors, maybe they have a ton of medication, maybe there's a mental health component, and if you can coordinate all that and have that sort of, the patient-centered medical home concept, I can certainly believe that that would make that person healthier. So what Medicare did is they introduced these codes, the chronic care management codes, and then one that we'll talk about a little later, which is called transitional care management. The chronic care management, what's interesting about this code is you have to spend at least 20 minutes, which physicians will spend that a lot more than that and not be reimbursed for kind of the administrative piece that goes into this. So this code, it's coded in 99490, so that's the CPT code. You have to provide 20 minutes of clinical staff time that's directed by a physician under general supervision, or it can be another qualified health professional, like a nurse practitioner or a PA. Nurse practitioners in the state of Kentucky, it's not the most friendly state to nurse practitioners, but it's pretty darn friendly. They have a huge scope of practice here. Nurse practitioners can do a lot of work, and you see more and more physicians bringing them into their practices, so that team concept really helps. So the patient has to have 2 or more chronic conditions. So the physician, they would have to spend 20 minutes of clinical staff time doing things that you're probably already doing, like coordinating that person. If the person is sick, they've been in the hospital, they get out of the hospital, you want to coordinate so they're not right back in. Sometimes if they're sick, they have pneumonia, they come home and their power's off, or they're not able to get out and get food. All that's part of the care coordination concept. So that's the administration piece of this code, and you have to spend 20 minutes per patient per month. This code is not automatically paid. Medicare has a few codes like that, but they're very few. So you have to work for this code. You have to provide that 20 minutes of administrative kind of non-face-to-face time. And again, the patient has to have 2 or more chronic conditions. The chronic conditions have to place the patient at significant health risk. What chronic condition really doesn't already do that? The physician knows what is considered chronic. It's up to his or her medical judgment. So there's not a specific diagnosis code that would go on this claim. Just if you deem that as a chronic condition and they have 2 or more, that passes the test. You do have to establish a comprehensive care plan. Well, electronic health records make that a lot easier, I think. But sometimes the care plans have a tendency to fall short. They maybe have some things that are unanswered. So what they did is they actually spell it out, what they want the care plan to look like. This is the only part I'm worried about, which is why I also am going to talk about the transitional care management, which does not have this loophole. But they do exclude certain things. So they're saying that if you were a practice that was affiliated with an accountable care organization, you could be eligible, but we would have to double check that. You cannot build transitional care management and chronic care management for the same patient at the same time. Medicare has a lot of codes like that. They call them overlapping, bundled. They won't permit you to bill both of those. They consider that a double dipping, which is why transitional care and chronic care are really 2 different programs. The thing that worries me is that first bullet, though, and I'm not sure what kind of grant, but I don't know that you all fall under this, but if you had practices that were in the multi-payer advanced primary care practice demonstration or the comprehensive primary care initiative, there's already money for that as part of the funding that CMS provided, so they won't pay chronic care management separately because they consider that double dipping.
Can you go back and define what an accountable care organization
an ACO. I wish I knew what an ACO was. We only have a few in Kentucky.
I said there's 5. I didn't say there's 5
Yes.
in Kentucky.
At one point, when the ACOs were first started, there was enormous amounts of money out there on the table with that first round of ACOs. And what they do is that the physicians are sort of trying new kind of new methodologies to get better outcomes, and they have to take more risks, so the ACO sort of helps them with that. But everybody has a different idea about what that really means. If you go to the CMS website, they actually have a whole page on accountable care organizations. So to get started on the chronic care codes, it's in your particular grant, you're already part of what happened is the patients, as I understand, already have 2 or more chronic conditions.
Mm-hmm.
So you already sort of meet that first bullet. They're Medicare patients. They do have to have the multiple or 2 or more. They're supposed to last 12 months. Again, the doctors, the physicians know what a chronic illness is. I put some examples up here. That's not all inclusive. This is where people really get confused out in the practice management world. This is not all inclusive. This is just a sample. Again, the physician determines what the chronic care. One of the things that you do have to start the chronic care management, the physician, at this point, if their patients have been Medicare patients for more than a year, they're going to have to perform a comprehensive evaluation and management. So that in order to sort of jumpstart it, you've met the first criteria, that's a Medicare patient. They have 2 or more chronic conditions. Then the next thing the physician would have to do is he would have to render an annual wellness visit. The IPPE visit is that welcome to Medicare. They have to get that within the first 12 months, so I'm going to say that's off the table probably. Most likely the physicians that are treating these patients are going to do a comprehensive E&M. So they are required to do a comprehensive E&M to sort of jumpstart it. With the comprehensive evaluation and management, there are several components to that code. They would have to do probably a review of systems would be the easiest.
So it could be just an E&M code.
That's right.
Or the annual wellness visit.
Yeah, and the annual wellness visit for Medicare actually pays pretty well, but there's a lot of components to it. For electronic health records, what I usually tell practices to do is search for patients with 2 or more chronic conditions, that those conditions are expected to last 12 months or until death. Create a log. There is a component we'll talk about in a minute. The chronic care management is really an interesting code because the whole point is a care coordination, but it's to get the patient involved. So you really have to get the patient, you have to explain it to the patient, and you have to have them sign something that says that you've explained it to them and that they're now part of your chronic care management. Also, who may furnish the chronic care management is beyond the physician. So it can be a physician in any specialty, and I get that question a lot. We always think when we see these kind of things it's going to be in family practice, primary care, internal medicine, but actually you could have somebody like a pulmonologist where the patient has maybe end-stage COPD or severe COPD, but they also have heart disease and they have diabetes, but their COPD sort of is taking over their life, so their pulmonologist is really the primary doc. A certified nurse midwife is part of the eligible population, clinical nurse specialists, nurse practitioners, and physician assistants. So as long as they're performing within their scope of practice, and again, in our state, the scope of practice for nurse practitioners is growing. The qualifying clinical staff is defined by CPT, so CMS did not do that. Basically, the American Medical Association publishes the current procedural terminology books every year. That's your coding books. So the qualifying clinical staff is defined by the CPT code. One thing I do like that Medicare did is they made this general supervision. It's not direct. General supervision is very wide open. It's like the physician is leading, so that's kind of nice. And this year, a federally qualified health center and a rural health clinic now qualified to bill for CCM. So we do have a lot of FQHCs and RHCs in Kentucky because we're just that kind of state. We have several. So for 2016, they're now eligible. Previously, they were not. This is important. I put a big red one. It's kind of red. It's not U of L red, but it's red. Only one practitioner may be paid for the chronic care management service for a given calendar month. So if work was performed by a nurse practitioner or physician, both of them can't bill. One needs to bill. So a lot of practices have the physician led, and they'll have nurse practitioners, PAs, and other staff, and they just bill incident to under Medicare with the physician's number, and that's acceptable for this too. But both cannot bill for the service. Not saying that a nurse practitioner couldn't bill for this service in the event the doc was out of the office or something, because they could. Is everybody with me on that? But only one of them can. And it's per calendar month. You've got to do the work. Medicare just won't automatically pay you. If you don't submit the code, you won't get paid. So you have to do the work, document that you did the work. One practitioner bills each month. One of the most important things about this code, anything that's time-based, whether it's 20 minutes worth of time, you need to make sure you document every minute of that 20 minutes. Medicare is a stickler for time-based codes. They have a lot of them. Critical care is time-based. I've seen so many audits where physicians will have to pay back money simply because they didn't document the amount of time they spent. So you've got 20 minutes. Each month, you're probably going to spend a lot more than that, but you have to document at least 20 minutes. And that 20-minute time is things like it's per calendar month. When you're coordinating the care for that patient, maybe you're talking to a social worker. That could be somebody that you had to get in touch with. You might have to get in touch with some other component of the community. Maybe the person does need some nutritional help. There could be all kinds of things going on with that patient that's going to impact how healthy they are. It could be a pharmacist. It could be any number of people that you would talk to about that patient in the community.
Physician or the nurse practitioner or PA or any of these people are the ones that bill. But my understanding was the 20 minutes just coordinating the care could be a medical assistant or a receptionist. Or
That is such a good question to ask. And CMS, they had a call on this where they clarified that. It can be other people. That's the whole point of the care coordination.
You're at the doctor.
And when you're trying to get that person healthy, I mean, you may have to reach out to 4 or 5 different agencies sometimes. And maybe they're a patient that's on Medicare that qualify for Medicaid and they didn't even know it. They could be adult eligible and don't even know that, although Medicare, they're doing a better job with that, but it's still, that's possible. Nutrition seems to be a big one, like getting the right food, making sure that person has access to food, and medication reconciliation is huge.
So what if the physician sends them out for like a diabetes self-management class or chronic care that we're leading? Can we send like some type of a document or our certificates? They could show the certificate that they was at class for 50 hours.
And then Medicare would also pay separately for that. So Medicare does pay for it. That's an underutilized service with Medicare too.
But it has to be a evidence-based, approved by CDC, and Stanford is not, so like, it could be paid for that.
But there are, yes, you can do it that way.
Okay.
As long as you can do that, you maybe have the same situation with another kind of specialty outside of nutrition. That's the one that always comes to mind first, but you may have to refer them to, maybe they're having a problem with their vision. It's just any number of things. Maybe you have to refer them because there's a mental health component.
Right.
And that, of course, happens quite a bit too. What happened at the group in Northern Kentucky that did this program, they have a huge coding and compliance department, and what they do is they may be talking to an agency about multiple patients at the same time. It's like, well, we need this for Ms. Jones, this for Mr. Smith, and blah, 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 and what can you do? There's not a limit on how many Medicare patients could be involved in your chronic care management program.
And
It's
what I
what you can
found
manage.
is just, and the families call in or the patient calls and they have a question, that I document the 20-minute, I mean, those are on conversations.
Family time is a big one because they're worried about their mom or their dad.
Sure.
And they have questions about medication.
As part of our grant, we have a community team that's going to be out in the community working with these patients like referring them with diabetic self-management. But one of the things we were going to ask is that we would go back to the practitioner and report back to them like what's going on with the person in the community, what we're doing with them. So we would request that doctor's time briefly. Could they bill for that consulting with us as a community team? Because we're.
You mean could he document that as part of the CCM and
Yes.
bill that? Yes.
Okay.
And the community involvement, I'm glad you brought that up too, because that's the whole sort of the foundation for this code.
That's right.
For the chronic care, and it is for any care coordination. You've got a few groups that are sort of trying to stick their toe in the water with this, and you've got the MCOs talking about it, but nobody's really doing anything about it. You're the first group, actually, that I've talked to that has a grant, that has money to try to figure this out,
Okay.
which is kind of exciting, or at least I think it is. The expectation, of course, is that they live at home or just a rest home or assisted living. They cannot live in a skilled nursing facility because Medicare has a whole different reimbursement model for that. And they have to basically be in one of these. It's really a residence. All of those things that are listed there, Medicare considers as standard residence. So nobody in an SNF would qualify for this, and certainly not, while they're in the hospital. But once they're home and you're trying to keep them away from those places, that's when you can do your best work. This just sums up the code. It's per calendar month, 2 or more chronic conditions. A big piece of this has to do with the care plan for the patient. So
Can I ask really quick? I thought there
Yes.
was 2 codes, a 9949.
there is, but they'll only pay for that one.
Yes.
Yeah, there is 2 codes, but this is the only one they'll pay for, so that's the only one I
I think
put
the
up
other one
there.
will be used in the future or
I
something? Or
do. They do that sometimes when Medicare has their own, even though this is a CPT code, Medicare also has HCPCS codes. Sometimes they go outside CPT and do things, but in this case, because there is another code, with the movement toward, with us transitioning to a quality payment system, I do expect that other code to get some, a fee assigned to it. So the EHR is gonna make this easier because a big component of this chronic care is this care plan. Because it's like planning for the whole idea. The concept is you got chronic care coordination to keep everybody out of the hospital, out of the skilled nursing facility, out of the ER. So the care plan becomes critical. So Medicare has sort of outlined the things they want you to do. You have to meet the components that are listed there. So you're going to record essentially the patient's demographics, what their problems are, their medication allergies, and the EHR does that now. You're going to create a structured clinical summary record. Every time I go see my physician, he prints it out and hands it to me. And sometimes he highlights what I need to do. You have to provide a copy to the patient. That was a funny question that came up on the call. We spent about 5 minutes talking about that, and I was like, I wonder where this person is calling from, because all the practices I know sort of do that automatically now. It's like if they have an EHR, it creates the care plan. If you're being treated for diabetes, or you're being treated for elevated cholesterol, then it's got your medications on there. If you've got lab tests, when you get your summary, it shows you where you are on your labs. If it's you're diabetic, it'll show your A1C that. So that's what they want you to do. They want to make sure that the patient gets a copy of that care plan.
So, when we were doing this in our office, we kind of, the Family Practice Association came up with a care plan, and we just kind of used
Yes,
that.
it's wonderful. There's more on the next page. But the big thing is, again, at the core of this particular CPT code, you have to maintain regularly updated electronic care plan that's based on an assessment of the patient's need. So once you give them their initial care plan from that comprehensive E&M visit, the expectation is this is a very sick person that and their health may fluctuate, so you're going to just reassess and document it. That is all it is.
They have to sign it. The care plan, the patient has to sign it.
They do have to sign kind of an agreement.
But they don't have to actually sign the care plan.
No, it's really an informed consent. So you do have, that is a component. They do not have to sign the care plan, no. This is just the checklist I put together. And it is much shorter than the family practice. You have to do the problem list, what the outcome and prognosis is. One of the things that Medicare sticks on is the measurable treatment goals. You want to make sure you have that in there. I see a lot of times with PT and audits on PT, they get in trouble for this because with physical therapy, there is some kind of outcome you expect, but they don't always list that. So whatever that treatment goal is, it needs to be measurable. You got to admit the symptom management, plan intervention, community social services ordered. That's going to take up a lot of your time, in my opinion, for working with this particular population. A description of how the services and agencies outside the practice is going to be directed and coordinated, schedule for periodic review, and then revision of care plans. So that's just kind of a quick checklist. One of the things that you have to do is access to care. But you're doing this, I don't know anybody that's not doing this already. Physicians must offer 24/7 access to a member of the care team to address urgent chronic care needs and facilitate care coordination in order to bill. So in other words, if you have a patient who has some sort of episode, there has to be someone within the group that can deal with it. It doesn't have to be the physician, but they have to deal with it right away. Again, then the thought is, maybe it's something we can deal with and avoid a trip to the ER, maybe not. Or maybe they do have to go to the hospital and you still have to kind of document that and keep up with that. You have to make sure that you have the routine appointments as needed, and you have to coordinate your referrals. We talked about that one. Then you come to the managed care, and another big piece is that it includes follow-up after ER visit. Some of the coordination seems like it should come from the insurance company, but Medicare is not going to notify you when that person went to the ER. We have an advisory group, and that's one of the things they've asked the MCOs for over and over is, tell us when you have the patients that are frequent flyers at the ER, because we don't know that if we're the primary care doctor. Well, Medicare is not going to do that. So the expectation is, and this is why you have to get the informed consent from the patient, they also need to understand that they need to reach out to the care coordination group. So if they have to go to the ER or they're in the hospital, there has to be a follow-up with that patient to maybe try to avoid that the next time.
So when a person goes to the emergency room and they tell who their attending is, there's not automatically?
You would think it, but I heard over and over that just doesn't always happen.
Wow.
My doc is part of Kentucky One now, and they do that. But not everybody does that. Medicare patients, they don't think about that, because if they're in traditional Medicare, they have all these options. They can go to any hospital they choose, and they may like one over another. So it doesn't always happen. That's a great point. This is where you have to get the patient's written consent. So before you can bill for this, during your comprehensive E&M visit, you're going to have to talk to the patient and say, okay, we're entering you, if you wish, into our chronic care management program. You have to explain what that means, how it's going to work. You do need to share with them that information about that patient will be shared with all that patient's providers. That could be mental health providers like social workers. It could be any number of healthcare practitioners. The patient can terminate at any time by revoking consent. They are responsible for copay. This is one of those services is not paid without cost sharing, so the patient will pay a copay and deductible. The practice can certainly collect the copay and deductible. I'll talk about that in a second. Talk about how you can actually make money off this code. Only one provider can provide CCM services at a time. We talked about that earlier, so that's just a reminder. So this is where you do the checklist with the patient. You go over their care plan. There's no national patient agreement. There's some templates out there. CMS has a template, and there's probably other associations like the family practice that have templates for the informed consent.
We found this to be the hardest part because, a lot of times the families are calling in and you don't realize till after the fact, oh, I can bill for this month. Well, they're not gonna be seen that month. That's the whole reason they're calling in, because they don't wanna come to be seen. So it's like, we were thinking in our office, it's like maybe January 1st, I mean, everybody in our office has 2 more chronic conditions, so we should just get everybody to sign this consent as part of like their annual
Just
paperwork, you know.
put them in the program, yeah.
Because I don't know how else to do it, because what we've done is we mailed it to them, and then they were supposed to mail it back, but they never mail it back. And when we were at these national meetings, everybody was afraid that the patients wouldn't want to pay the copay, because they're gonna have to pay every month. Potentially, if you bill this every month, they're gonna pay a copay every month.
Oh.
But most of these patients, when I've talked to them about it, they don't pay a copay anyway, because their secondary insurance pays the copay. So
Right.
it's,
The reimbursement for this code, not super, because this is really more on volume than, it's about $42.
it's how much the doctor gets paid.
You'll get paid 80% of that $42. So
And
it's
then how much
less
is the
than that.
copay then? I guess it's just
Then the
$20
copay would be the
whatever.
difference between what Medicare approved and paid. So 20%. Yeah, and
20,
then if
oh.
it's the first of the year, they have an annual deductible to meet with Medicare too, with the traditional Medicare. But if they have a supplement, or they're dual eligible, if they're Medicare, Medicaid, then of course they wouldn't pay a copay either.
I'd read that they're going to be increasing that amount each year for a couple of years, and 55 or 60 or something like that.
In this
Is that
code,
right?
they're gonna increase the code.
With Medicare, as part of because we eliminated the sustainable growth rate, the SGR, last year, then for the next 4 years, physicians are guaranteed a small bump in the fees. That's absolutely right. Just remember that patient consent, that's that informed consent, you have to do that. Document your 20 minutes. If the after hours care is provided, document that. I liked your comment about the phone, that's in my notes. Phone calls and emails with the patient, document it. Set up a system, and you probably have this in that group in Northern Kentucky. Theirs is a little elaborate, but they record every second. But you do need some sort of system that'll keep track of the time you spend on the non-face-to-face, like speaking to a family member for 20 minutes. It may not be one person who does the whole
Yeah.
20. Time spent by phone, other electronic communications with other clinicians, facilities, community resources, caregivers, that's a big one. Time spent on prescription management, medication reconciliation. You need to document the death or transfer of a patient. And if you have to transfer care to oncologists or cardiologists, etc., then you'll have to document that as well. These next slides give you, I took this right from the CMS website. It is the scope of service and billing requirements. And I like the way they laid this out, because they give you the 2 columns and they're fairly easy to read. For the reimbursement for this code, again, it's about, it hovers around $43. But remember that you can bill that code for each one of your Medicare patients that are enrolled in CCN each month. So if you see a large Medicare population, if you're seeing 100 patients in your CCM program, times that times 43, and then you'll get the physician will get 80% of that amount. There are billing limits for this code, but they're not terrible. You could not bill for the transitional care management, which is another option for you, and we'll get through that very quickly. There's 2 codes in transitional care management. So if you opted, if the physicians decided that they didn't want to use this chronic care management program, then TCM is another option, and the reimbursement for transitional care management is significantly greater than CCM. If they're in home health, that's considered double billing, so you couldn't bill if the patient was in home health and you were trying to bill for home health supervision, then you couldn't bill that while you're doing chronic care management, because you can kind of see where that's an overlap service. If they move to hospice, you're doing hospice supervision, you can't bill that. And if they're end-stage renal disease, that last codes, those are codes that Medicare pays on a monthly basis, and you couldn't bill those. So basically, these are the codes that you cannot bill with CCM. So this transitional care management is another option. And this these codes have been out since 2013, but this is more about when the patient has been in the hospital, because now with Medicare, if the patient is readmitted within 30 days or they leave, they get an infection, the hospitals are losing millions to penalties. And we had a couple of Kentucky hospitals that were actually hit very hard. So these transitional care managements codes were developed back in 2013, and the thought was that it might be able to help with some of that. Keep them out of the hospital, or at least if they go in the hospital. So what these codes do is they do connect the patients to community services, just like the chronic care. They're transitioning from inpatient settings, just like with chronic care, and it's to prevent readmissions, which is just like chronic care, and you have to have a care plan. The same professionals, physicians, certified nurse, clinical nurse specialists, nurse practitioners, PAs, they can all render the TCM services. The difference here is, to qualify for a TCM, you have to leave one of these settings. So if I'm a Medicare patient and I've been admitted to the hospital or one of these others, inpatient psychiatric, long-term care, if I am leaving one of these facilities and I am going to one of these, which is exactly the same as chronic care, so I'm leaving one of those facilities and I'm going home, that's when these transitional care codes may be billed. And the thought is, once these people get home, again, if you go home and you don't have any heat, you don't have any food, there's other things going on in your house that the physicians don't always know about, then you could end right back up in the hospital. So those are the kind of things that these codes help do. There are 2 codes here, and these 2 codes, the difference in them, they're both, the patient can be new to the practice or established. The only difference between the codes is one is moderate medical decision and the other one is high. And with dealing with a patient that is coming out of the hospital or one of those other facilities, you wouldn't expect to see low complexity at all. So you could bill a 99495 if it's moderate decision, and you have to bill a face-to-face visit within 14 days of discharge. If you wanted to, if it was a high medical decision complexity, so you have to see the patient within 7 days of discharge. It can be any diagnosis, it doesn't have to be a chronic. So for conditions that require TCM, typically they will be conditions that the patient had at the time of the discharge. There's a lot of work that goes into these, because just like there's a lot of work that goes into the CCM, so the physicians have to make an interactive contact with the beneficiary or the caregiver within 2 business days. 2 business days following the beneficiary's discharge to their community. So when they left the hospital and they went back home, then you have to follow up with them within 2 days. And what happens is, a lot of times you are not able to get in touch with the patient for many reasons within 2 days. So you have to document your attempts. Then you can document that it has taken you longer. They give you examples. So within 48 hours, for Medicare purposes, attempts to communicate should continue after the first attempts in the required 2 business days until they are successful. So it may take you days, but as long as you're documenting that you're attempting to get in touch with them, you could go beyond that 2 business days.
And usually they're just calling to make an appointment in that 7 days. You know, that's like, there's a phone call.
And that should be when they leave. If you know you're going to bill for those transitional care management, then that should be part of the protocol. You're absolutely
In the
right.
hospital setting.
The transitional care, there are non-face-to-face services that are part of this. They're a little, you can look and review the discharge information, which you're doing already. Review the diagnostic test treatments. It's standard protocol, really. You may have to provide education to the patient. Again, the main difference is it's just one's a highly complex medical decision making within the first 7 days, and then there's a moderate within the first 14 days. Those are the biggest points of the TCM. I even added this from the CPT. It tells you the type of decision-making, the number of diagnoses and so forth. But it has to be a moderate or a high. There are coding limitations with this. You can't bill chronic care and this at the same time. These codes are very well reimbursed, and I'll go over that in a second. You also can't bill care plan oversight, medical team conferences, end-stage renal disease. So really, all of the things that are listed here are the no-nos.
The medical team conferences, even if the patient is present, you can't.
Mm-mm. Because that's sort of part of that code. Medicare has, they consider that sort of a double dip. And then the complex care coordination would be what we talked about previously, and the Medicare medication. So these are but even with that said, this is one slide of codes that you can't bill, but you can certainly bill for all of your office visits, your evaluation management services, diagnostic services for that patient, whatever else they may need. That seems to be the big one, is that you can't, you have to pick between CCM and TCM. And a lot of times it comes down to how much staff you have and your expectation for revenue. These codes, absolutely, because the reimbursement on these transitional care management codes are much higher than evaluation management services. So it's a way to transition them back into their world and making sure that they have everything they need.
So for that 30 days, you could bill the TCM, then the following month go to the chronic care one?
You could do that.
Okay.
And that would give you the revenue for the TCM, and then it would give you the long-term revenue for the CCM. Medicare's really trying to come up with ways to engage physicians and patients in their care.
And to keep primary care in business.
And to keep primary care in business, because the incentives are gone. So Medicare's trying to help. So they offer the TCM. So when the patient gets out of the hospital, out of one of those facilities that we talked about, you can report this TCM within 30 days of the discharge. Again, it's the same thing. They're only going to pay for it one time for the physician or nurse practitioner. One of the things that people get confused on this code is the date of service, because you have to wait the whole 30 day. You've got to do the 30-day period, and so that gets a little confusing. The place of service was another thing. That's going to be where you rendered that face-to-face visit. So it probably will be your office, but it might be some type of outpatient. We talked about this. This is the family practice documentation sheet that you can use for transitional care. This reimbursement has changed. I was looking at it, it's actually a little higher than that. But if you're participating with Medicare for the high complexity, you're probably going to get about right around $250, somewhere like that. And for the moderate, the approved is about $158, I think.
And the regular NM is like 100, isn't it?
Yes, the transitional care management codes pay much better than the evaluation management, which is why I'm surprised that more physicians don't use these codes.
But let me ask this, if the patient gets re-hospitalized in that 30 days, can they still bill or not?
No.
That's the issue. That's
So
why you're
basically
holding
taking a
it.
gamble.
Yeah, you
That's
are
why
with
you're
the
holding.
transitional care management. But the thing is about the TCM, you can't, that's true, you can't bill it like twice in the same month. But you can bill it once, and you're still gonna see that patient
it's
in the
over
hospital and in the office and be reimbursed for that. Which I think there's still quite a bit of confusion on this code.
That's why you have to hold it for 30 days.
It
because
is.
if they get readmitted during that time, you can't bill.
Yes.
Then I think what happens if they get readmitted during that time, you could change that transition code to just a regular E&M code.
You can.
But then it's.
You can bill for the services outside the transitional care service that you do. So if you're seeing them for an evaluation management, you can bill for that. That's absolutely right. It is the 30 days, but the reimbursement on it is probably one of Medicare's better reimbursed codes.